Take 10. Just kidding. So today we're going to talk about another group of transfer medications, specifically those that deal with rate control. And there are two medications in this class, and they are diltiazem and esmolol. So we'll talk about diltiazem first. Diltiazem, also known as cardizem, has a very rapid onset of action, I'd say within 5 minutes or so, and it lasts about 1 to 3 hours. Now that's a plus or a minus, kind of depending on what you're doing with it. If somebody gets into trouble, it's a negative effect because it's going to take about 2 hours to go away. Both of these medicines are used to treat inappropriate tachycardia, which can just include inappropriate sinus tachycardia, SVT, AFib and aflutter, and then they're also used, and primarily for this indication, esmolol for thoracic aortic dissection to decrease the shear force of each beat. If you think about it, when an artery dissects, it's kind of like that blood flows like a hammer pushing those tissue layers apart. So the more that happens, the more the tissue dissects. So of course, cardizem or diltiazem is a calcium channel blocker, and it slows conduction through the AV node, and it does not really affect peripheral calcium receptors like nifedipine or amlodipine. And of these two medications, for heart rate control, it is by far my favorite because I find that this is anecdotal. I find that I can control the heart rate before inducing hypotension, specifically for AFib and aflutter, whereas the opposite sort of applies when I use beta blockers like esmolol. I tend to run into problems with hypotension before I get the patient rate controlled. And interestingly, this is kind of borne out in the literature where 25% of people being blocked specifically with esmolol become hypotensive, whereas only 3.5% with diltiazem. And that is not anecdotal, that is from the literature. So my anecdotal experience seems to be verified by studies. Now, we will be using cardizem probably more often than esmolol, but in the field, because cardizem requires refrigeration, we are going to be using esmolol. But you're going to have to be, I think, familiar with both of these medications. So we're going to go on to esmolol. Esmolol is also known as Brevibloc, and it blocks beta-1 receptors. There's beta-1 and beta-2. Beta-1 is responsible for the chronotropy or the heart rate, and beta-2 actually causes bronchial smooth muscle dilation, so like you would get with albuterol, which is a beta agonist, and it lasts about 15 minutes once it's turned off, again, as opposed to the roughly 2 hours for cardizem. So that's an advantage, again, of a drip where you can turn it off and just have someone revert to normal, especially if they get hypotensive. But as I said again, about 25% of people on an esmolol drip are going to become hypotensive. But fortunately, only half of them, or 12.5%, are going to be symptomatically hypotensive. So when you're infusing either cardizem or esmolol, of course, the first thing you do if someone has unacceptable hypotension, they're either profoundly hypotensive or symptomatic, you turn off the drip, you give them some fluids, and you follow the protocols, and pressors if needed, I guess, would be a last resort. Esmolol is quick acting. It starts acting in about 2 minutes. And one thing that's kind of interesting is that because Esmolol only affects the beta-1 receptor. If you were to use that, and we will never do this, I'm sure, but in combination with something like epinephrine, you would get unopposed like beta-2 stimulation, and so you'd end up helping the lungs, but causing actually hypotension by stimulating the beta-2 receptor, which causes smooth vasodilation, I should say, in the smooth and in the peripheral muscle tissue. So anyway, that's it for these two agents. See you in the next video.